The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome to all you TMD warriors out there. We're gathered here for the next episode of TMD Demystified, and I'm Tony Urbanic. Today, we are going to be talking about the problem of having TMD misdiagnosed as dental pain, or the opposite, dental pain being misdiagnosed, just misdiagnosed dental pain ending up TMD. Let's title this TMD misdiagnosed as dental pain. I knew this was a problem because over the past 12 years since I've been on this project and seeing more and more patients, treating more and more patients every year, I began to see more and more patients filter into the office with obvious misdiagnosis from dentists and endodontists that have thought one way or another that the pain the patient was complaining of was dental pain, which turned out to be TMD. So let's title this thing TMD misdiagnosed as dental pain. The problem actually is bigger than I thought. I can describe what I have seen over the years in a minute, but what really tripped this was my introduction to a recent article that was reviewed, a scientific article that was reviewed in I'll give him credit, drbicuspid.com, who had a article in that site which was entitled 50% of endodontic patients with toothaches had TMDs. And so I'm not going to read you the whole article because the article is really just a portion of the scientific article itself, or basically an abstract. But the article itself was published in the Journal of Oral Rehabilitation. And the article that was the abstract was published on April 6th. Excuse me, the published article was published on April 6th, and it appeared on drbicuspid.com very recently. But the original was in the Journal of Oral Rehabilitation, and it is believed, according to this article, is the first study to assess the prevalence of TMDs using a validated TMD diagnostic criteria among patients with a history of tooth pain seeking endodontic treatment. So endodontists are definitely involved, or if you do endodontics in your general dental practice, you are definitely involved with the possibility, actually the probability, that you're going to misdiagnose dental pain, which is actually TMD pain. And we'll explain how that happens and why that occurs. I can explain that easily. The study itself took 100 people that participated in the study, 63 women and 37 men. And the findings among these participants, the prevalence of TMD in those 100 patients who, in the prior 30 days, attended a university dental clinic for non-surgical endodontic treatment. And the prevalence in those 100 patients of TMDs was 54%. In 26% of the patients, The TMD pain was unrelated to endodontic treatment. In other words, separate from the endodontic treatment. In 20% of the 100 patients, the TMDs contributed to the patient's chief complaint. And here's the kicker, and the sole source of the pain was TMD in 8% of the patients in this study, according to the authors. So obviously it can be confusing because you can have two problems at the same time. You can have a hot tooth, you can have a pulpitis and TMD at the same time, because they examined each one of these 100 patients with criteria to determine whether they had symptoms of TMD. And again, to reiterate, 54% showed that they did have TMD, which coincides with what I have stated and the number that I use, which is the number I derived independently of this study, for sure. I've always said that 45% of females have temporomandibular joint symptoms of one kind or another between ages 13 and 75. And I derive that, explained that many times in these episodes. This study showed that 54% out of 100 patients, male and female, both 54% had TMDs, and that a portion, 26%, had TMD unrelated to their endodontic symptoms. So they had endodontic symptoms plus temporomandibular joint symptoms, but that in 8% or 8 out of 100 of the patients that they were seeing to do root canals on and thought they had endodontic services were necessary, and that they had a tooth that needed endodontic therapy, 8% of them, or 8 out of 100, actually had TMD and did not need root canals. And that coincides with pretty much what I've seen in our practice here over the past 12 years. So what I see and have seen frequently is a patient coming in, and it's so common that when I see this, I get very suspicious and modify my history to ask a few extra questions. But here's what usually trips my suspicion is I'll walk in the room, the x-rays up on the television, on the viewer toward the ceiling, and I stand there and I look at the x-ray a minute, and the patient is billed out or recommended to see me because of TMD. So that's all we see here anymore is TMD patients. And I'm looking at an x-ray and I see one of two things that trip my suspicion. Number one, I see a normal dentition throughout the mouth, except for a series of missing first and second molars. If there's a third molar there, it's gone. Maybe a second bicuspid, second premolar is gone. Usually unilaterally, but I have seen it bilaterally. So what I'm looking at is the normal looking dentition. In fact, with very few operative procedures performed, very few, if any, crowns or in fillings, but a bunch of missing teeth. And the first time I saw this, I stood there for a minute. It didn't make a whole lot of sense. It's like, and the oral hygiene was good. The bone support was excellent. The age of the patient didn't indicate that they should be having any unique kind of dental bone loss or dental problems, but in what appeared to be otherwise a normally healthy mouth, either unilaterally or bilaterally, and it can be in the maxilla or the mandible, 2 or 3 teeth that were missing in a row. And in the episodes that I saw that, or the corollary, which is to see, rather than missing teeth, a normal looking mouth, good hygiene, with a row of root canals done. And when I see that, I ask the patient, what's going on here? And then they will describe to me the pain that they had, and that they went to their dentist, and their dentist, and this is what happens most of the time, this is the history most of the time, their dentist said they could not find anything wrong with the teeth that the patient was complaining about the pain was coming from. And then I would say, well, if the doctor couldn't find anything wrong, then how come the teeth are missing? And the patient would say, well, I just said you got to take the teeth out. Or in a discussion with the doctor, that between patient and doctor, they decided that, well, he couldn't find anything wrong with the teeth, but he's going to go ahead and do the root canals. And basically what you're left with is either missing teeth, a row of missing teeth, or a row of root canals that did not need to be done. And again, this coincides with this study. I believe it's out of the University of North Carolina. Don't quote me on that, because I did not pull up the original study. That 8% of patients who presented for root canal treatment actually didn't need root canal treatment. And fortunately, in this study, they were able to determine the difference. And in the private practices or practices, sometimes the doctor cannot tell the difference and goes on with either extractions or root canals inappropriately. And of course, that leads to a lot of confusion and a lot of extra expense. And then the patient is left with potential problems of either missing teeth or root canals that need to be done. And then most likely, eventually the teeth need to be crowned. And a lot of extra dentistry needs to be done, when the simplicity is that if it's diagnosed correctly and early enough, all you need to do is put the patient into a posterior disoccluding splint, and over the period of a proper protocol, make the symptoms go away. Now you probably are next saying, well, how do you differentiate? Okay, let's talk about that first. And that's just simple dentistry and what I talk about consistently about how to diagnose TMD. But, the usual modalities for treating a pulpitis, for diagnosing a pulpitis or a need to do a root canal is, electric stimulation, cold stimulation, or percussion, or combination of all three. But if you can't get the tooth to respond in all three of those, or any or all of those three diagnostic modalities, then the next step from the doctor would be to press on the temporomandibular joints to see if they're hot from the open and closed position. You've seen me do this multiple times, where open widely, press firmly into the glenoid fossa, and close rapidly. If it hurts, the joint is inflamed. If they have an inflamed joint, they have temporomandibular joint disorder or disease, a hot joint, inflammation within the joint. Normal joints do not hurt when you do that. Joints without inflammation don't do that. And the definition of TMD should be, it isn't depending on which textbook you read, it's not there, but it should be TMD is inflammation of the temporomandibular joint, because then inflammation will cause all the symptoms. But you have to start out with inflammation within the joint to create the symptoms. So the differential diagnosis between dental pain and temporomandibular joint pain, inflammation within the joint, is super simple. If you percuss the tooth, if you put an electronic stimulation on the tooth, or you use heat or cold, usually cold, on the tooth, and they do not respond, then you should be very suspicious. And if that hurts, you're dealing with TMD. Now, the next question is, how does inflammation within the temporomandibular joint mock itself up so that the patient thinks that the tooth hurts? Well, that's pretty easy to understand. And I believe, now I'm going off into common sense, anatomy, physiology, neurology material, but I don't think that the inflammation in the joint causes a pulpitis within the tooth itself. If it did, the tooth would be sensitive. The tooth itself would be sensitive when you percuss it or put cold on it. What happens is, as I've discussed so many times before, the inflammation in the joint itself creates a autonomic sympathetic system to tighten up the muscles of mastication. And those muscles of mastication and those signals can go out to any of the muscles of mastication. And the ones that are affected most frequently are the muscles of the forehead, of the jaw, underneath the mandible. And when those muscles tighten up, they pull on the bone at the periosteum and stimulate the nociceptors in the periosteum. So if you get the masseter muscle here getting a signal to tighten up, and it constantly pulls on the bone in and around the second or first molar area, the pain is going to be experienced on the surface of the mandible. And as you know, patients, when they describe their symptoms, they're not really good at describing their symptoms. They just know it hurts, and it can easily be confused. Pain in this area can easily be confused in the patient's viewpoint, not in the doctor's viewpoint, but in the patient's viewpoint, as dental pain. And they swear, my tooth hurts. It hurts right there. That's where my tooth is. When actually the pain is coming from where the muscle pulls on the periosteum, stimulating the nociceptors, sending the signal back to the central nervous system, stating there's pain right here. And the patient thinks it's a tooth. When the tooth is examined, it's negative. And then what do? Well, then what you do is this. And if it's positive, you've made your diagnosis. This study just came to my attention just within the past 24 hours, and I thought it worth a brief episode in the podcast to describe it to my colleagues. It is actually more common than I thought. I would not have thought that 8% of patients presenting with what they thought, or the initial diagnostic dentist thought was dental pain, sending him to an endodontist. I did not think that the number would be that high, as 8% actually had no other problem other than TMD. But it does coincide with what I've seen in our very large practice treating a TMD non-surgically, because those patients filter in not infrequently. And those are just the patients who have already lost teeth or had series of root canals. There are a lot of saves. There are a lot of patients who come in who have been to their dentist, and the dentist says, no, the tooth is not symptomatic. I'm not going to take out the tooth, or I'm not going to do a root canal. And one way or another, whether they referred in by that examining doctor or they somehow or another were referred into our practice to consider temporomandibular joint disorder, we were able to make a proper diagnosis and treat them. And magically, according to the patient, magically, their dental pain went away. So dental pain actually is a verified symptom of TMD. That doesn't mean the tooth itself hurts, because I don't think it does. The tooth is not symptomatic. What does cause the pain is pain in and around the mandible in the area of can be maxillary tooth also. Can be the maxilla, can be the mandible. Most of the patients that I've seen have been mandibular teeth removed or root canals. But I have seen patients complain of upper teeth, number 14 and 15, number 2 and 3 frequently. I think that's enough for today. I've made my point. I hope that you considered in your practice, both if you're an oral surgeon, because you will see this. You will see patients filtering in for tooth removal that actually have TMD. If you're a general dentist, when you're trying to distinguish between, does this tooth need a root canal or not? When you see a healthy tooth and healthy bone and the patient says the tooth hurts, obviously you're very suspicious. if you do your diagnostic series and you find the tooth does not respond, please think of TMD. I think you'll be surprised at how many patients come across as positive for TMD. With that being said, I look forward to the next time you can follow along on this episode that I can speak with you. I encourage anyone who'd like to communicate with me to do so. I can be reached at Tony@tmjservices.net. Our Director of Marketing and Communication, Naomi, can be reached at Naomi@tmjservices.net. If you'd like to find out more about the Urbanic device and protocol and how you can apply that to your practice, to grow your practice, to solve the problem of TMD non-surgically easily. I want to emphasize easily. I would like to do an episode or two on how easy it is to treat TMD patients and get rid of this nonsense that TMD is such a hard thing to do. Patients are difficult. It is just not true. But if you'd like to communicate with us, we're happy to do that. If you need more information, it can be seen at www.tmjservices.net. And I'm always ready for criticism. If anybody would like to criticize anything I bring out, I'm happy to respond and discuss it with you. For today, I am Tony Urbanic, and this is TMD Demystified.